start um, my talk by saying that ocular genetics should not be as confusing as many ophthalmologists and many colleagues feel it is. Yes, I do understand that there is some different language that we talk, some definitions and terms that are we're not aware of, but ocular genetics is something that is very important and is something that is changing ophthalmology. It is changing the way we diagnose our patients and definitely will change the way we treat our patients. Moreover, ocular genetics can be life-saving and life-changing to the patient, just like what Dr. Arif Khan showed us in the previous presentation. So what would make me think that this condition or this sign is something that is genetic? If I see a sign that is bilateral and it is more or less symmetrical in both eyes, especially if there's a family history, then we are dealing with an ocular genetics case. I'll try to go in a systematic approach. First of all, when examining the optic disc, never miss the mild optic disc pallor, the temporal pallor that we do see in many of our patients. But if this patient is having a defective vision, then that's a sign for you to take care of. Always ask about family history. You may be able to detect an autosomal dominant or a mitochondrial inheritance that will fit in with this sign. Optic disc hypoplasia, again, a sign that could be easily missed in a busy clinic, but it is, again, a life-changing and life-saving finding because you are the one who will detect this and send this patient for endocrinological workup and imaging. Going outside of the disc, we find the vessels, and the best place to assess the vessels is just when they emerge from the optic disc margin. This patient was referred to me because of unexplained visual loss, and I examined him on the slit lamp, and with the 20D, you really don't find much, but there was slight vascular attenuation, arteriolar attenuation, that prompted me to do a series of investigations for him. And as you can see that on the optos, the macula does show this darkening and dyspigmentation that was not obvious on the slit lamp examination or on the fundus examination. What was obvious was the arteriolar attenuation that we see. Vessels don't always have to be attenuated. They can be dilated. And this would lead us to search for hemangioblastomas and save the child or the patient from complications of the von Hippel-Lindau. Second, we move to pigmentations. Pigmentations, we have dark pigmentations and we have yellowish depositions or deposits or pigmentations. The bone spicule-like pigmentation, nobody would miss that. If I just want to request something for you, for my colleagues not to miss is the word like. We don't want to say bone spicule pigmentation. We don't want to say bone spicules in the retina. We say it's a bone spicule-like pigmentation. They don't always have to be that shape. They can be circular or nummular, as this patient that presented to us. We can see the rounded pigmentations with the periarteriolar sparing. This points out to a CRB1 retinopathy. The pigmentations can take different forms, shapes, and sizes. It could be this large triangular pigmentation. This points out to choroideremia more than retinitis pigmentosa, and what would confirm that is that the vessel caliber is not much affected in relation to the atrophy that we find in the retina. These oval pigmentations, fish-shaped pigmentations with deep depigmentation of their margins is a danger sign, especially if there are multiple and scattered all over the retina, because that could be a sign of FAP, and that's atypical trophy, and you would need to refer that patient. Yellowish deposits could be discrete, they could be diffuse, they could be discrete like in Malaysia levantinese, or they could be diffused like in pattern dystrophy. But what I want to say is not all what is yellow in the macula is an age-related macular degeneration. When you see these discrete, dispersed lesions all over the fundus, observe carefully. If you find these drusen to be at the nasal side of the fundus, this is pointing to a retinal dystrophy. A finding that is very subtle and is very important as an early sign for retinal dystrophy is the loss of the choroidal vessels. Usually in Caucasian patients, on examination of the fundus, you will easily find and see their choroidal vessels. When this is absent in a patient where you're expecting to see it, this points to an early retinal dystrophy, as with the loss of the foveal reflex that we see in our patients. A very important point here, if we are dealing with a patient and we're expecting a retinal dystrophy, especially that we find that the retina is very atrophic and very attenuated vessels, we're not expecting the macular OCT to give us this thickness. When this happens, always suspect something a little bit sinister than just a retinal dystrophy. This may be the only patient that I insisted his father do a genetic testing, and unfortunately I was right. This child had a CLN3 pathogenic mutation, and CLN3 pathogenic mutations cause neuronal ceroid lipofuscinosis, which is Batten disease, a very debilitating and deadly disease. You have to educate the patient, you have to counsel them, and you have to give them some warning signs. And if you want to know why the patient's father, months after the diagnosis was done, sent me and tried to call me at 1 a.m. asking for help because his son had nightmares, I would invite you to attend our Mayor conference in Egypt on the 17th of December. I have more to say about this case. Last but not least, a normal fundus. Never miss if a normal fundus is appearing and you're still expecting a retinal dystrophy, please do order electrophysiological studies and keep going behind this case. And thank you very much.
Thank you very much. Again, we listened to an excellent talk. And I would like to ask you about any questions that you would like to ask. Okay.
I have a question from Dr. Arif Khan. How often do you image a patient in whom you've just seen Lisch nodules and Caffolet spots? MRI brain to rule out glioma. Rule out glioma.
So the question is, how often to image a patient who has Lisch nodules?
Yeah. You establish this patient has neurofibromatosis.
Yes. For me, what I would do actually, if the patient, this is a whole different topic about what to do with optic nerve gliomas. But if the patient has reduced vision, obviously the patient needs an MRI. If the patient, and then to be followed. If the patient has good vision, I don't necessarily think you need to get a baseline MRI. You can follow these patients with VEPs. That's a good way to follow the patient. But the decision about, most of these optic nerve gliomas in neurofibromatosis do not need treatment. They're the exceptions that need treatment. So if the patient is, and the treatment is not it's not easy. So if the patient has good vision and good visual function, even if there is an optic nerve glioma, we don't treat it. So I would say the patient can be followed by electrophysiology. If they're starting to lose vision, then you have to investigate further with MRI, and they really need to go to a center that has experience in this because there's some controversy about how to treat these, and most of them don't need to be treated.
Thank you.
Is there age that you can say the parents that, okay, we are done, no need to more follow up in this kid? Let's say like after 18 years of age, can we tell them that it's okay, we can be relaxed? Or
I would never let a neurofibromatosis patient go. I would say, if everything has been stable and they're older, I would start to say yearly exams, but I would never let them go. I was talking about the anterior segment, but there's actually a sign in the eye much more powerful for diagnosing neurofibromatosis, more powerful than leash nodules. And that is when you do near infrared imaging, like when we do an OCT, we always get a near infrared picture. There are these choroidal melanotic lesions, which are actually more specific for neurofibromatosis, and they're earlier. So that's actually, but I was supposed to speak only about anterior segment, so I didn't talk about that. Because as many of us know, the leash nodules don't come until they get older. So if you have a 4-year-old who doesn't have leash nodules, that doesn't mean they don't have neurofibromatosis. But if they do have it, then that's something.
another question?
Just thank you very much for your smart talk, and just wanted to say I understand it was only anterior segment, but when you have the thing that you see on nystagmus, it's mandatory to go to OCT because, of course, if you have a foveal hypoplasia, so it could be albinism, but it could be also something very special, which is congenital aniridia and PAX6 mutation, and sometimes you have congenital aniridia with no iris anomalies, which is strange to say that, but it's still PAX6 mutation and without any iris anomalies. So this is interesting too, I see.
Yes, absolutely. Sometimes you can get a slit lamp, but you can't get an OCT. But obviously, any child who comes in with nystagmus should have an OCT, definitely.
Okay, good, thank you.
Of
You
the
want to
retina, of the
comment on
fovea.
this?
My talk was anterior segment.
Yeah.
Okay, Dr. Tarek, would you like to
child-
comment on this?
Yeah, I
Subject?
will write to
Yes, because the foveal hypoplasia could be very subtle, and I do agree that an OCT would be very helpful because its grades and clinical examination, especially in a nystagmic eye, nearly impossible.
and it's impossible also, it might be impossible, but I try always to do even if I will take only the scan and cannot capture, because the nystagmus in a child for OCT is really difficult to do.
Yes.
But ERG, I think it will add a lot.
Of
You
course.
will, of course, in these cases, and of course, if a cooperative child and to do him multifocal, it will also add a lot.
Yes, sure. Thank you.
I think, and correct me if I'm wrong, not all cases with foveal hypoplasia had nystagmus. Not all the cases. Sometimes you have foveal hypoplasia grade 1, 2, and 3 without nystagmus. And sometimes you have it, right? What? So,
The nystagmus in albinism is not necessarily from foveal hypoplasia
Exactly.
because they have a miswiring at the chiasm. They have abnormal decussation, and this causes abnormal binocular vision. This causes nystagmus independent of visual acuity.
Exactly. Yes.
So that's another very important point, that when you see nystagmus, they don't necessarily have reduced visual acuity. They can have 20/30 vision and have nystagmus in
Yeah.
albinism, but it's from the decussation, not from the foveal
Yes,
hypoplasia.
exactly. This is right. So I would like to add, for all cases of nystagmus, especially those who are referred to the ophthalmology clinics, it's better to do an ERG to rule out retinal causes for nystagmus, like Leber's congenital amaurosis, achromatopsia, enhanced Iscon syndrome, blue cone monochromat, CSMB with high myopia and nystagmus, and of course foveal hypoplasia. Isolated form, and the one with aniridia or albinism. Okay, so
Thank you
it's
very much.
a lot of things. So.
I would like to ask our panelists about their any comments that they would like to add or say or ask.
I think I prefer to do both ERG and OCT.
Both of them.
Because in some situation, one of them may not be reliable findings, then you can compute both and then you can arrive at a diagnosis. So it is a package for me.
Yeah.
If I want to do something, I do ERG, probably even VEP if the vision is lesser, and OCT. So whichever we are able to get the results, then we can try to interpret.
Actually, I want to say that I'm very proud with the ocular genetics session. It's small but very effective for any pediatric ophthalmologist. Actually, I might find the pigmentation, the hypopigmentation, the spicules. I would be minded more with the refraction and whether there is a solution for the patient or not. But they please think twice and send those patients for the clinical geneticists or the pioneers in this field like the great Dr. Arif Khan and the Dr. Tarek Saad. Thank you so much.
If you're lucky to have one of them, I should say. Okay, now it's the part. Yeah,
have
you are
Dr.
lucky.
Tarek.
Now we are in the second part of our session is the myopia management update. It's a very hot topic for us because we have a hope to stop progression of myopia, and there are different tools for it. And Dr. Dominique Bramogignac from Paris,